This is the second talk in the series on quality improvement, and this is going to be the one where I talk about the details of the quality improvement processes. Again, I'm going to make sure that you get note pages of all of these talks so that you can write notes while you're listening. I think that'll make it a lot easier because there's a lot of detail in this particular presentation, and I'll go over the detail even more in subsequent ones. The objective of this presentation is to describe the quality improvement process, but I also want to talk about two models that focus on quality improvement: to define and identify benchmarks, to define and identify outcome measures, to spend some time moving through the PDSA cycle, which is the steps of the quality improvement process. And just in case you're curious, I want to spend a few minutes talking about the difference between research and quality improvement. There are three key questions to the quality improvement process, and these are the overarching outline of what we're going to be doing, although the underneath part of it is much more detailed than this. But the first question is, what are we trying to accomplish? And that's usually a broad aim. And remember, I asked you in the last talk what kind of things you were concerned about, problems you had with your practice. This is where we ask, what are we trying to accomplish? So, for example, in my practice, I might want to improve the outcomes for my patients with type 2 diabetes. The next question is, how will we know that a change that we've made is an improvement? And so here's where we need data. We need a measurable goal. So how do you know that the outcomes of your patients with type 2 diabetes are better? Well, maybe their A1Cs are down. And how do we know that's an improvement? Because of national guidelines and benchmarking. And then the next question is, what change can we make that will result in this improvement? In other words, what are we going to do to get to this measurable goal that we want? And this is where we go into evidence-based practice, also some guidelines, and I'll talk about that in great detail actually, because that's obviously the most complicated part. What do we do to make a difference? So let's talk for a few minutes about what we are trying to accomplish. And this slide is just, there's really nothing more on it than that. It's pretty though, isn't it? Well, there's really a couple of levels of aims or goals, whatever word you want to use. But for example, there's the mission level, there's the practice level, and these are the big picture items that I asked you about last time. So you want to implement perhaps a quality improvement program, or for example, the nurse practitioner in my clinic wants to start a diabetes program, a structured program for our patients, and she's very excited about that. And so that's a mission level, a big aim that you might have. Then we drill down to the specific project we're working on, and the aim might be that our average A1C is less than 7, or that 80% of our patients with type 2 diabetes have been screened for depression, or that 80% of patients with chronic obstructive pulmonary disease have self-management goals in their chart. So these are very specific. So you can see how you've got a general aim, like improved diabetes outcomes, and then specific measurable aims or goals, such as 80% of our patients have been screened for. So you can see how these are different. Another pretty slide. How will we know that change is an improvement? Well, we know change is an improvement in several ways. You've probably heard of the concept of benchmarking, where we use national guidelines or benchmarks. You need quantifiable measures, and that means, by quantifiable, I mean something you can measure. It can't just be, it feels good or it looks good. You have to have a measure like the blood sugar or the A1C or the blood pressure or the lipid. Or, for example, whether or not a test has been done. The answer to that is yes or no. That's quantifiable. Did a patient have an LDL done last year? That's yes or no. So that's a quantifiable measure. You need to know the differences between what your practice is and the national benchmarks. So national benchmarks, and you can find these in many places, but we'll say that your patients with let's say your patients with diabetes need to have an LDL of less than 100. We know that's the national benchmark. Well, what's your practice say? What do your data say is the average LDL of your patients with type 2 diabetes? Do you meet that benchmark or not? So you go to these national guidelines, such as the National Heart, Lung, and Blood Institute, which is NHLBI asthma guidelines, or you go to PQRI or AHRQ. These are all places, and I'll give you a handout. I don't have it ready yet, but I will soon, a handout of all sorts of places you can go. If you're billing Medicare and Medicaid, you want to go to the CMS website, the Centers for Medicaid and Medicare, and look at their PQRI, and your billing people need to pay particular attention to this, because you can actually use these benchmarks and say you're doing this and get billed at a higher level, and so that's an important motivator. And so there are lots of different places you can find benchmarks, but these are some of them: national guidelines, or places like the Centers for Medicaid and Medicare, and I'll send you some information about that. This should look familiar from our last talk. So what you measure, there are process measures. For some reason I seem to have these mixed up. I usually do outcome and then process, but I have process measures, which is what we're doing. So are you going to measure what you're doing, such as the percentage of patients who've had at least one A1C done in the last 6 months? Or in the case of my patients, it's more likely it has had one every month for the last 6 months, which is just as bad. It's just that, like I said, these young people don't always read the chart carefully. So we all have our problems. I'm not a perfect example of how to do things right. And then we have outcome measures. So how is the patient doing? And again, the A1C, the LDL is a good example, or the total cholesterol, whatever you want to use. And then the balancing, like patient satisfaction data, access to care, referrals, those kind of things. When you're looking, and I could spend a lot of time, and I hope you all have that manual that I wrote about doing quality improvement, because it's another place to go for detail. But it talks about this idea of when you're measuring something, you need to make sure that the measurement is valid and reliable, and that means that it's true. Valid means that it's true. It's really representing what it says it is. And reliable means that it's reproducible, that if you measure it multiple times, you'll get the same result. And that the outcome or quality measure is modifiable. I mean, for example, you obviously don't want a goal of changing somebody's sex unless you happen to have a practice where that's what you do, which is very rare. So modifiable, you can't make somebody older or younger, or change their gender. So it has to be something you can modify. It has to be a measure that is a reasonable clinical goal in your practice. So, I mean, you're not in New York City. You're in Red Cloud, Nebraska, or wherever you are. So somewhere out there in the beautiful Sandhills. And so it has to be a reasonable goal for your clinic. The data collection process has to be feasible. You've lived that experience for the last 2 years. So I know you know what works and what doesn't work in terms of collecting data. And it has to represent the overall aim of the project. I mean, you don't, if you want to improve type 2 diabetes outcomes, then you don't want a quality indicator like patient satisfaction. Not that that's not a good indicator, but how does that really tell you that unless the patient satisfaction is quite specific to diabetes, then it's not a direct indicator of the aim. And so those are all things to think about when you're looking at what you're going to measure. I think at this point I decided to do away with the fancy slides on the questions and just go right to the question. And so the third question is, and the third question, the hardest one, is what change should we make? What should we do to make a difference in our practice? And so we have to analyze the problem. If we find out that if we look at our data and see that the mean LDLs for our patients with type 2 diabetes is 120 and the goal is 100, then why? Why is it 120? Is it errors in what we're doing? Is it substandard care? Are we not giving people medication that we should be giving medications? Are we not setting the right goals? What is our goal? Again, going to the practice guidelines. So like I mentioned, the LDL, the goal is 100, so yours is 120, so you know that you're not in the right place. But it might be, are you checking people's LDLs every month? And then what should we do? Okay, so we're at 120, we want to be at 100. What should we do? And there's some models that we can use that we'll look at for that. But a lot of times, what I've done in my practice, and it's worked very well, is we just all sit down and brainstorm, and that's the front desk. I remember we had a problem with no-show rates, and I'm You probably do too. We had a terrible no-show rate, and we sat down and brainstormed. The front desk was involved. I mean, should we be calling people to remind them who was no-showing, why were they no-showing? And, what we finally determined that most of our no-shows were, in fact, people who called with acute problems who didn't get an appointment for another 2 weeks because that was the next available appointment. So by the time their appointment came up, they were better or worse, I don't know. So one of our solutions at that point was to save a block of one provider every day had open appointments for acute visits that we didn't start scheduling until 4 o'clock the afternoon before. And so he was available only for acute visits. It kept him busy. Our no-show rate went way down, and it was all based on brainstorming. And you couldn't make that decision without having the front desk there, as well as the medical assistants and everybody else. And then you do rapid improvement cycles, and that's what we're going to spend a lot of time talking about. But you can't go to rapid improvement cycles until you've, again, gone back and decided what is our overall aim, what is our goal, what is the problem, what should we do. And then the improvement cycles are how you test what you're going to do, and we'll talk about that at some length. Well, evidence-based practice, you probably hear a lot about that anymore, and this is just really the idea that what you decide to do, your intervention, your goals, all of these are based on evidence, on research, on doing the right thing. And there are standards of care, baseline descriptions of quality. They may be discipline focused, and I realize I have this NP example here, but certainly in family medicine and primary care, there's lots of standards of care that are out there that you can go to. The American Academy of Family Physicians is a wonderful website with resources for that. Clinical guidelines, guidelines.gov or AAFP, lots of places to go. Critical pathways, usually more common in acute care settings, and protocols, again, more common in acute care settings. I want to spend a few minutes talking about a couple of organizing frameworks for change. And then one of them, the chronic care model, we're going to spend a lot more time talking about and really using it as the tool to approach quality improvement. But I will talk about some other ones, and I just do really like this slide color. So this is the chronic care model. I've never really cared for this picture, but the whole point of it, and we'll see it in another slide that's more clear perhaps, is that there are 6 areas here that are in that blue, that sort of aqua blue circle that are what it's all about. There are 6 areas that you address for how you improve health care. And the first is on the left, there's the community resources and policies. The next one is self-management support strategies, and those 2 are sort of patient-centric. And the other 4 on the right-hand side are more practice-centric. And so you've got the healthcare system and the organization of healthcare, and really the big thing at that level is what we call organizational support. So for example, I'm the director of my clinic, and so the way I support quality improvement is I give people time to do it, I give them a small budget to do it, I encourage them to do it, provide the resources for them, sort of serve as their cheerleader, and so that's one aspect of improving clinical outcomes. And then the other 3 that are in the healthcare system side are the delivery system design, how you organize, how you deliver care, such as the time of your appointments, whether you go out to people or have them come to you. Decision support, which is how you know what the right thing to do is, and then clinical information systems, which is what that whole patient registry system that you've been working with is about. And all of that together results in an informed, activated patient, a prepared and proactive team. And then you get improved outcomes. It's a very nice model developed by a man named Ed Wagner, who I happen to know. He's a really great hero of mine up in the Oregon area. This is the same thing, only in a narrative format that I think, frankly, is a little bit easier to follow. And here are the 6 things that are in the care model. And I put chronic in parens because nowadays they're spending more time calling it the care model, because although it was started to deal with chronic illness care, it's really a lot about just all sorts of it. We find that it works in other things too, like preventive health care. So the system-focused things are the organizational support, the information systems, better data management, clinical decision support. Patient-focused are the delivery system design, self-management support strategies, and community resources. Another model that's at the website, and again, this is going to be on the list of resources you have, and you really will like this one. It's the Institute for Healthcare Improvement, and it's ihi.org. And they've got an incredible amount of information that will help you with quality improvement there. And they have a model called the Triple Aim Initiative, and they're trying to optimize the system by taking into account the experience of the individual, the health of a defined population, and cost effectiveness. And it's one strategy to redesign primary care services and to structure that are focused on optimal access. And another strategy is population health. And I'm going to show you the image, and we're going to talk through it. It's sort of like that Swiss cheese thing. So take a slow, deep breath as we go to this image and give me some time to talk you through it. Okay, so here's the Triple Aim model. On the left there, you'll see those three components that should be considered simultaneously: the individual's healthcare experience, population health, and per capita cost. But really on the right, the secondary drivers are what you can focus on, and then in between are what are called primary drivers, which are big picture items. But on a day-to-day basis, the things that you can do are really in those boxes on the right. You can provide evidence-based care. You can collaborate on standard definitions. You can work on community outreach, work on handoff management. All of these are things on that fifth box down, at least a minimal defined set of benefits for the population. So it's I think, I like this, and I understand what they're saying, but I think it's very academic, and it probably won't work for you nearly as well as the chronic care model, and that's why we're going to work with it instead. But I just wanted you to know that there's this, and there are actually several other ways to do this, but the chronic care model is where we're going to go. But I just wanted to make sure you all knew that I knew the AAA model, and this is in the IHI website. So all the different ways that you do improvement involve a cycle. All improvement is small steps that you get feedback. It's a feedback loop of just trying a little bit and making a change and seeing if it works and modifying it, doing a little bit more. And there are lots of different models. You might have heard some of them. Six Sigma, Lean are two models. The Institute for Healthcare Improvement is where I tend to go, and so I like it because it's healthcare specific, it's very accessible, and a lot of their material is, in fact, most of it is free. The focus is on the three questions that we asked. What is our aim? How do we know our change has made a difference, and what do we do to make change? But then the core is these rapid improvement cycles that are also called PDSA cycles. And again, sometimes this language, don't let this language get you confused. Just stay with me here, and we'll try to work through it. And you can always email me, if you don't understand something, and I'll get back to you. Okay, here's a PDSA cycle. I don't generally like the way it's done, and then to make it worse, the second plan is supposed to be a do. But so you start at the top right, which is the plan. What is your objective? What are the questions? What are you going to carry out? Who's going to do what, when, and where? And then the second one that says plan but should say do, and I don't know why my copy of this is wrong, you actually carry it out, you do it. And then you study it. Okay, what are the outcomes of what you did? And then you act again, which is to say, okay, what are you going to do next? And you plan. And so that's how the cycle goes. It's an old Deming model. This is old quality improvement from the auto industry, I think is where it started. So the first thing you do is you write out, you plan. So what is your test objective? And then who's going to do what when, and what are the predicted outcomes? And then you do it. What happened, and did it work or not? So I remember once we were working on a form that we wanted to use for our patients to set goals on. So our test objective is this goal setting sheet going to work for our patients? And so who was going to do what when is that one of the nurse practitioners, Lisa, was going to use this with 3 of her patients and set goals with them. And the predicted outcome is it was going to help the patients to set goals. And then the do part of it is what happened. Okay, did Lisa, and then there's always when. So you usually do this in a very short time frame. So maybe Lisa was going to do it with 2 patients over the next 3 days. And so the predicted outcome is that it would work well. And so what happened? Well, the patients had all sorts of questions. Lisa didn't understand how it worked, and there were some issues about one piece of it. So the answer is yes, some of it worked and some of it didn't. So that's the plan and the do. So then we study, okay, what didn't work? Why didn't it work? What are we going to change to make it work better next time? What are the lessons we learned? And then we go to act. How are we going to modify it? What's our new plan? And we go back to another cycle. And so it's very small steps. You'll see me say this later on, and I can't say it too many times. But it's one person with 3 patients over 2 days. I mean, it's very, very small numbers each time you do it, and you go back and analyze it because you don't do, what happens too often, you've seen this happen, is you come in and try to change the whole system at once. It doesn't work. Small, frequent changes that are modified before they're spread are going to be much more effective. And they're much easier to carry out. They're not so overwhelming. They're not so resource intensive. So what are we trying to accomplish? Well, we want to improve the health of our patients with type 2 diabetes. That's pretty straightforward. How will we know that we've improved the health of our patients with type 2 diabetes? Well, 2 ways. We're going to look for a lower A1C, average A1C. Mean means average. Forgive me, sometimes I throw in scholarly terms. So a lower average A1C. And we're looking for a process outcome, which is an increase in the percentage of patients who've actually had an A1C done in the last 6 months. Now think about this. This actually could be a negative. The one could negatively influence the other, because if you get up to 80% of your people have an A1C done in the last 6 months, they may not all be good A1Cs, and it may actually raise your average A1C. So let's see. I'm trying to find there it is. Okay. So again, we have to ask, what changes that we make will result in a change? Well, we have to ask ourselves, why are the A1Cs so high? And I use as an example, another good example is let's talk about provider inertia, because the providers may not be motivated to maximize their meds. For example, we now know that we need to get these patients on insulin much, much earlier than we used to. And, a lot of providers are really resistant to that. It's a lot of work getting patients on insulin. We're not sure exactly what kind of insulin to put them on. Insulin is expensive. There's all sorts of issues regarding getting them on insulin, and they may not be comfortable doing it. And so one intervention, if it's a provider problem, they're just not motivated, is to do what's called a decision support intervention, where you get some training for the providers on how to initiate insulin in people who are on oral medications, and then what's the least expensive way to do it? And then patient behaviors. Maybe it's a patient problem. They're not being good patients. They're not being compliant with their lifestyles. They're not exercising enough. To me, for my patients, it's much more often, yes, they're not eating well, but it's much more likely that they're not moving enough. And then the cost of the medications is a real barrier. You can say, well, sure, I want to put my patients on insulin, but Lantus costs $100 a month, and my patients can't afford that. And so we have to look for pharmacy assistance or some way to get help with that, or maybe put them on NPH, which is a lot cheaper. So what changes can we make? And I want to point out that there are 3 different areas here that we've looked at for changing to get this A1C down. So it's not just one behavior, it's not just one focus, it's multiple things that you could be doing at once. The team, you may have a big team, and some people, one person says, I'm going to go out and find out about how to get pharmacy assistance for Lantus. And another one says, I'm going to work on self-management support. So you can work on these all together. So the other change that we talked about was the fact that people's A1Cs are being measured too infrequently. So why is that? Well, maybe it costs too much. And so is that the barrier? Patients aren't getting it done because it costs too much? What are the community resources? Maybe we should do point of care testing. How much would it cost the clinic to buy an A1C machine and do it? Would that save the patient money? And so if we did that, that would be a delivery system design change. Again, going back to the chronic care model, community resources, delivery system design. Maybe patients aren't scheduled for planned maintenance visits, so you never get A1Cs because they only come in for acute problems. And it's, you're busy worrying about the acute problem, you never think about drawing an A1C. So maybe there's a delivery system design where the clerk, the front desk person at checkout says, I know you were in today with a cold, but you've got diabetes, and so let's schedule you an appointment in 1 month to come back for a diabetes check or a cholesterol check. So there are 3 important points here that we'll go over again and again. But one is that these are small trials with quick turnarounds. So maybe try an intervention with 2 patients in the next week. With multiple cycles, it's easy to experience aim drift. And so you need to be revisiting the aim cycle, the aim frequently. And so don't forget that, even I, when I'm talking about it, can find myself drifting away to, something else. And so remember to keep focused. And so when you're really working on quality improvement, it's a good idea to have a lead person whose job it is to sort of coordinate all of this and make sure that you're regularly revisiting the purpose of the projects. And to remember that this is not research. You can have multiple things going on concurrently, and that can be very confusing to a person who comes from a scholarly research background. It works better for me. I mean, I've got a scholarly background, but I sort of like having multiple things going at once. But traditional researchers, this will make them mad. But I suspect that out in the sandhills, you don't have many traditional researchers, so I hope this will work out. And I think my next slide is about the whole thing about the difference between research and quality improvement. Yes, it is. I am psychic. So here's some things for those of you who have come from a scholarly background and say, well, how do I know when I'm doing quality improvement? How do I know when I'm doing research? Well, quality improvement, the intervention is multifactorial. In other words, you're looking at systems and patients all at the same time, and it really is about best practice. It's about rapid improvement cycles. There should be no risk to the patient. You're not experimenting here. You're trying to get the right practice, so you're trying to get the right thing that we know is right done. The audience is the organization and the patients. The data source is the organization and the patients. There are no controls. There's no control group over here that you're not trying it on. You're doing it on anybody who walks in that fits the criteria. And so it's not generalizable. In other words, what you find out works doesn't generalize to the whole universe of primary care practices. Now, that being said, the whole point of some of these collaboratives is that you can share things so that you might have other practices that you can say, well, we did this tool and this worked and that worked. In fact, if you go on places like the IHI website, one of the things they do is share a lot of things that work. Research, on the other hand, is an untried intervention that's being tested. So there is risk. And so there has to be a very complex protocol that's involved that does not exist with quality improvement. And the audience is not patients or the system, but is the scientific community. And the data sources are the randomized population, multi-sites, and the design focuses very extensively on controls, all about control. Those are probably the huge difference between QI and research is the absence of control and quality improvement. And research, because of the way it's done, is generalizable. So we can say, okay, we have tested this model in this population, we've compared it to this control group, and we can say that this, improved outcomes by 50%. And you cannot do that with quality improvement, but that's not what quality improvement is for. So the conclusions of this presentation: quality improvement is an essential skill for everybody in the practice. And I hope I probably didn't say that as clearly as I should from the get-go, but I think you heard that throughout. This isn't just for providers, it's for everybody. This is for the front desk person, the coding people, everybody involved in the practice should be involved in quality improvement. There's certainly many leadership opportunities in quality improvement in ambulatory settings, and so this is a chance for your practice to take the lead in this, or perhaps somebody in your practice to say, you know, I'm really turned on to this, I'd like to do this. We all need to expand our quality improvement skills and implement them as a routine part of practice. Your next assignment. Okay, this is more specific than your last one. But I need you to identify in your practice an aim related to heart disease or diabetes. An aim, remember, is a big statement. I want to improve our outcomes. You can be more specific and say LDL or something like that. And then, in fact, you probably should. So you want to lower the LDLs, the average LDLs of the patients with heart disease or with diabetes in your practice. And then identify data that you've got based on the data you've been getting from the project for the last 2 years to support the conclusion that you're really not at the aim that you want to be at. And so let's say you want your average LDL to be less than 100, and today it's 120 for your population of 100 people with type 2 diabetes. And so what is your benchmark? Your benchmark is 100. And so that's one benchmark. And then identify 2 strategies, 2 interventions that you're going to try to achieve that. And go back to that chronic care model and think about the types of strategies. You know, there's self-management strategies, there's delivery system design, there's clinical information systems. So what strategies, what might you focus on in order to try to reach that aim? I don't need you to implement anything at this point. I just want you to write those things down and get that information to me so I can give you some feedback, so we can start interacting on these things. I really need to start interacting with you all. I hope you have this memorized by now, but if not, please send the information to me at this email address. I am Kate Fiant. That's Fiant like giant, and it's kate@integralnursing.com. Thank you very much, and have a nice day.